Welcome, everyone, to Hollander Rounds. My name's Allison Bond. I'm the medical director of Medicine Grand Rounds, and really excited for this iteration of our clinical problem-solving series, which was renamed Hollander Rounds about 3 years ago, we think, in honor of Dr. Harry Hollander, who many of us know. He has some fantastic diagnostician skills. And so the purpose of this series is really to talk to expert diagnosticians and have them walk us through a case and learn from their diagnostic reasoning as they walk through that. So we have two very special guests who are here for an encore presentation, Doctors Rabih Geha and Reza Manesh. They may not need an introduction to most in this room, but I will anyway. So Dr. Rabih Geha is an associate professor in the Division of Emergency Services and the director of education for the emergency department at the San Francisco Veterans Affairs Healthcare Center. He's the co-founder of Clinical Problem Solvers, which many of us are familiar with. It's a multimodal educational initiative with a weekly podcast and more. He went to Brown Medical School, then came here to UCSF for residency and chief residency in internal medicine. Dr. Manesh is an associate professor at UCLA. He's a director of didactic teaching at the Greater LA VA Medical Center. He is the other half of the CPS co-founding team, and is also the author of Finding Joy in Medicine, which is a book about sustaining joy in medical practice. He went to the University of Pittsburgh, where he got his MD, and then here to UCSF for medicine residency. So let's get into it.
Dr. Bond, can I just say something really quickly?
Please.
First of all, thank you for that very kind introduction. Many of you may be looking at me, those that know who I am, and wondering, there's something different, right? Tell the audience what's different. you have more hair than I have more hair than before. And you might say, well, how is that possible? Well, I remember when I was a resident, I was in the elevator with Harry. And I said, Harry, I'm struggling with my baldness. And then Harry said, Reza, baldness is something beautiful because your brain is closer to the environment to absorb facts. And then what happened was I was just getting too smart. So I rubbed my head against Rabih and boom, these follicles just sprinkled out. Anyways, I just had to get that off my chest.
I'm glad you did. Thank you. Yeah. Thank you for that interlude. I didn't want to say anything, but. And also, we can draw attention to the Hollander branding on their shirts. I don't know if folks online can see that, but it is in honor of Dr. Harry Hollander. So, excellent. So to go back to kind of how a clinical problem-solving case works, the ground rules are that our wonderful discussants do not know what the diagnosis is, and our goal is really to learn from them as they reason their way through it. It's really about the journey and not the destination. It's sort of a nice to have if they can get the diagnosis, but really the goal is to see how they make decisions along the way so that we can learn from that. We really encourage folks to ask questions, shout things out if they have ideas, and we really want to have fun with this. So we'll start with the history of present illness of this patient. So this is a 56-year-old man who has severe alcohol use disorder. He's brought into the hospital after being found unresponsive at home in the setting of recent vomiting. So very short amount of information that we have here, but what are your primary concerns when you hear a presentation or a chief concern like this?
Yeah, thank you for stopping at this aliquot. When someone's unresponsive, like my reflex thought, if I'm arriving to the patient's bedside in the hospital, is what's the point of care glucose? So immediately I want to know the glucose. And then secondly, did they take any substances which may have caused them to experience this unresponsiveness? I'm assuming that he's later going to wake up and we can change the frame to transient loss of consciousness. But, first things are first. I want to know what his vital signs are. Does he have a pulse? Because if he doesn't have a pulse, forget about the diagnostic journey. Just focus on saving the patient and start the ACLS algorithm. Once I confirm he has a pulse, what's going to be the most important thing besides the point of care glucose and making sure that this patient didn't take opiates or a substance that sedated him is going to be the history. And the history is really broken down into 3 parts. And probably the most important part is what preceded the event that led to the unresponsiveness. And how can we discover that? Well, we hope that he's actually living with someone that can convey to us what happened before this patient became unresponsive. Because nothing is going to be more important than that. I mean, we can keep waxing on poetically about this, but it just comes down to the ABCs: airway, blood pressure, pulse, point of care glucose, if you're able to do it, what meds is he taking? And then if there's a bystander, understanding what preceded the event, how long has the event lasted for? And
Awesome. Thank you so much. All right, so to answer some of those questions that you just posed, so the patient was brought in by his wife after she found him unresponsive, cold, and she described as mottled. 4 days prior to this admission, he was drinking alcohol heavily with subsequent nausea and vomiting. He was very tired. He had severe fatigue. And so he slept through most of the next 2 or 3 days before he was found by his wife to be unresponsive, as we discussed, and brought him to the emergency department of an outside hospital. So in the ED, we'll move on a little bit to what we see when he gets to the outside hospital ED. So he's ill appearing. He has a mottled face and trunk. He has cool extremities. He wakes up, he's able to provide some history, and he states that he noticed the bluish discoloration on his ankles and chest 1 day prior to coming into the emergency room. He notes that he has leg pain and arm pain on both sides. He has paresthesias from his arms and hands all the way down to his knees, and also has numbness of his legs and feet. So paresthesias, numbness of all of his limbs, essentially. And he reports that his pet dog bit him 5 days prior to this admission and broke his skin. A little relevant history there, perhaps. I'll move into his past history, and then we can take a little break and talk more about how we would digest the information that we just got. So past medical history, he has a history of alcohol use disorder. He had a transient ischemic attack in January of 2025, which was complicated by left-sided weakness. He has hyperlipidemia and hypertension. His medications include a low-dose aspirin, atorvastatin 40, and he has no known drug allergies. For his social history, he lives in rural Northern California with his wife and his pet dog that we heard about recently. He has not traveled recently. He drinks 4 beers every day, has a 30-pack-year smoking history, has a pet dog, as we mentioned, and no known exposure to wild animals or wild dogs. He works as a carpenter, has never really been hospitalized before, and doesn't have any known exposures to tuberculosis, never has been incarcerated, and not sexually active in the last year. So last slide before we end this aliquot. So his review of systems is notable for a lot of the things that we discussed previously. So fatigue, malaise, having some non-bloody emesis, this mottled purple skin, and these neurologic symptoms in all of his limbs with paresthesias and weakness. And everything else, as you can see here, he did not have. So that's a lot to digest. Can you walk us through a little bit how those slides and the information on them have really propelled you forward in the diagnostic process here?
Yeah, I have 2 pieces of advice. One on the medicine, which we'll talk about. The other is about dogs. Dogs can do no wrong. Prof. Rezah and I had a glorious 5-mile run with my dog this morning. So I would hate to overthink the dog, but that piece of history is certainly very tantalizing. I think what has changed fundamentally between the first aliquot and this piece of information is we realize that the brain is not affected in isolation. And I think rather that this is very clearly a head to toe systemic disease, literally. And so the mental shortcuts that I think one can try to take in such a complicated situation is to ask yourself, is this a multifocal systemic disease, meaning that there is different elements of this disease in different organs? Or rather, is this a systemic disease by definition? And what I mean by that is this entity fundamentally required to be systemic because it courses through the blood? And if you are having a blood-based issue, you cannot have it be anything but systemic. And so I think the tension would be, as you're taking care of this patient, is to ask yourself, all these other symptoms that you're getting, the neuropathic symptoms, the articular symptoms, I forget what other things, because there's quite frankly quite a lot. Do they represent foci of disease in those respective organs, or are they just a manifestation of a cardiovascular phenomenon in the purest sense, anything in the heart and the arteries and the capillaries and the veins? And the power of a very close physical exam to tell you, hey, this is a vascular phenomenon, by looking closely and saying, hey, when it's blue, is it blue like cyanotic blue, or is this a distractor blue? What are the pulses? And so I think the next round of evaluating what sounds like potentially a pretty critically ill patient is to understand, I think, that fundamental question. Is this multifocal primary organ disease that has nothing to do with the blood vessels, or is this a systemic disease that's required to be systemic because of the organ that it's in? And that's a higher level reflection. And I think a lot of the data that we're going to subsequently accumulate will help us try to make that fundamental distinction.
Great. Anything to add? What do you make of the term modeled? Like, what does that medically mean to you potentially?
Yeah, I think, whenever you have such a powerful description that's triggered by information coming to your ears, you want to be careful because you want to confirm it with something that's been trained over time, which is your eyes. And so what I'm expecting to see when somebody says modeled is essentially skin findings that make me think there's ischemia or hypoperfusion. And so, yeah, I think 5 years ago, I would have come to the conclusion that this patient has ischemic skin. Now, I would want to see it before I make that leap. But that's what it makes me think of, is that there's skin ischemia.
Great. So microvascular or macrovascular, and anything on that list of items, or is that differential kind of too broad before you see it?
Yeah, I think whenever you're saying that a organ is diffusely ischemic, it almost always is microvascular. So if you were to say somebody has a large MCA stroke on one side of their brain, macrovascular phenomenon over and over again. But if somebody's entire brain is offline from ischemia, you're likely dealing with small foci of disease in the smaller vessels. So yeah, I think it's a very wise question. I would say if you really believe this person has symmetric modeled skin everywhere, it probably is a small vessel phenomenon. If you're dealing with one leg that's modeled, I think the calculus changes significantly.
Great, thank you. So we can move on to physical exam and see with our trained eyes, as you mentioned, in the next slide. The patient was afebrile. He was tachycardic to 118 sinus. He was tachypnic with a respiratory rate of 21 and satting only 91% on ambient air. He appeared ill, had poor attention, but he was able to follow simple commands. He was noted to have scleral icterus. He was tachycardic on his cardiovascular exam with a regular rhythm, no murmurs. And he was mildly tachypnic without accessory muscle use and had coarse crackles bilaterally. His abdominal exam was unremarkable. It was non-tender, non-distended. He was noted on his arms and legs to have diffuse anasarca with dusky and cool extremities. He did have palpable radial and dorsalis pedis pulses. His neurological exam, significant for being fully oriented, being able to follow simple commands, but numbness in both arms and legs, and then to have some significant weakness of distal extension and flexion of his legs only, not his arms. So skin.
So modeled.
Yeah.
I'll leave the because Rabih loves photos, I'll leave the photos for Rabih, but if we can go back to the preceding slide. I think just quickly, I have to say this. In the Journal of Hospital Medicine, when we were on track to learning diagnostic reasoning, I used to print out Harry Hollander's CPSs and just study them. Like I may argue that I read them more than Harry read his own CPSs. And in one of them, it was titled The Hand That Feeds You. And it involved a dog, it involved a bite. And we promised we wouldn't just throw diagnoses and we will focus on framing the problem. But I just have to say one organism because it's just coming to mind that Harry taught me. And that's the reason I'm mentioning it. It's capnocytophagia. I'm just going to put that out there in the world that I learned from that CPS. But when I look at this exam, what we're trying to do is we're trying to frame the problem. And in framing the problem, we also have to incorporate the tempo of the problem. Tempo is queen in clinical reasoning. And we know whatever this process is, it's not subacute, it's not chronic, it is acute and progressive. So we have to track the tempo of this disease unfolding before us. Now what the clinician's mind is doing is seeing, are there any clues, any strong diagnostic clues that can help us frame the problem that we want to solve? You know, I'm a little surprised by the vitals. I was expecting hypotension, and I don't know if anything has been done to the patient yet, like fluids, et cetera, but it does surprise me that they are normotensive. They're tachycardic, not surprising. They're probably inflamed. Their tachypnea might reflect the substance that's accumulating in the lungs that we're auscultating as crackles, which could be water, pus, and we have to be open to the idea of blood because of the mottledness and what Rabih said so eloquently of microvascular ischemia. But the tachypnea can also just be lactic acidosis that's building up. But when you look at the hypoxemia and you couple that with the crackles and the tachypnea, you really feel like there is some kind of issue happening at the alveolar capillary level. The scleral icterus, I think we can't dismiss this finding. Like, this is something that we have to incorporate into our problem representation. And what the mind does to scleral icterus is just convert that to hyperbilirubinemia. And usually you need the bilirubin to be above 3 before you actually see scleral icterus. So as we are framing this problem, we said acute onset, progressive, the nerves are involved, the lungs are involved, the vessels are involved, and now the bilirubin, which may just reflect hyperbilirubinemia of sepsis, or it may be a clue to hemolysis, for example, but more labs will help us decipher that. The diffuse anasarca is so interesting, right? Because typically when we see cases of anasarca, it's on the orders of months to years. Like, this patient comes in, they're extremely swollen, and then we're like, okay, do they have a low albumin? Do they have heart failure? Do they have liver disease? But I think the list of what causes acute onset anasarca is much more narrower. And again, because we're worried about the vessels, thinking, is there some kind of leak happening leading to this anasarca? I'm not going to talk about the skin because Rabih will tackle that in the next slide, but I do want to talk about the neuropathy. That's quite unusual. I think an easy way to approach neuropathy, like anything in medicine, is one, the time course. Presumably, this patient didn't have any neuropathy prior to this incident, so we know it's acute onset. And then it becomes a localization exercise. And neuropathy ultimately is it mononeuropathy multiplex, or is it polyneuropathy? And here, it seems like it's involving multiple extremities. It's not in an uncoordinated fashion. So everything is yelling polyneuropathy. And we all know alcohol is one of the most common causes of polyneuropathy that starts in the longest nerves involving the feet. But when you have polyneuropathy that's involving the hands and the feet, after his drinking episode, you have to wonder, does whatever is happening here, is it also involving the nerves? And you can even make more progress because polyneuropathy is broken down into axonal and demyelinating. We've learned all this from our neurology friend, Aaron Berkowitz, who's really a huge part of CP Solvers. And when it's involving the hands and feet simultaneously, it sort of prioritizes more a demyelinating polyneuropathy. So I'm going to pass the mic to Rabih, but I think what this aliquot does for me is say, okay, acute onset, the nerves are involved, the hepatobiliary system is likely involved, the lungs may or may not be involved because he vomited, he may have aspirated, but I'm still trying to frame the problem for this multisystemic disease because ultimately what you put in AI or what you get out of AI is as good as what you put into AI.
So how would you summarize this if you were putting it into AI or trying to make sort of a one-liner?
Yes.
It's challenging with a lot of different parts.
No, I love that. And I'm accessing AI all the time. Open evidence, GPT 5.2 now. But I would say a 56-year-old man with a history of alcohol use disorder and some other past medical history that's really not relevant, who is presenting with acute onset unresponsiveness, hyperbilirubinemia, anasarca, and polyneuropathy and mottled skin. That's what I would put in.
Great.
All right.
Love it.
Did you put the dog right into AI?
Not in front of Rabih. I love Nar too much. He's the cutest dog in the world. No, I would actually. I totally forgot about the dog bite. Put that into AI.
Did you cover your dogs?
Yeah, I thought it was absolutely superb, and that problem representation is such an alley-oop to study the skin. And I think, yeah, the number of times I've seen this in real life is 0, 10 years out of residency, and so I think that tells you the seriousness and specificity of what we're seeing. And it's a little bit it's difficult to come to definitive conclusions on a physical exam almost ever, but I think you can come up with a definitive conclusion about what's happening to his skin. But let's just sort of start off with the most obvious explanation, which is that you see there is purpura, and I think the most obvious purpura is probably in the top right, thenar eminence, where you see these purplish lesions, right? So what does purpura fundamentally tell us? And I should say the way to confirm purpura is you want to make sure that that purplish discoloration doesn't go back into the blood vessels when you press on it. And it certainly looks that way just from seeing this milder versions of this entity. So you now know that there's compromise of blood vessels that have leaked into the skin, and those red blood cells are now in the skin, and that's why you can't push them back into the blood vessels. And purpura is a buzzword for many, many different things. In fact, in the realm of dermatology and rheumatology, it's evocative of vasculitis. So the question is this vasculitis? And the answer is no. What is happening here is fundamentally a completely different process to the palpable purpura of vasculitis that we know and love. This is not deposits in the blood vessel wall, causing the blood vessel wall to become fragile and bleed. And if you think about the most morbid complications of vasculitis, they're all bleeding. Bleeding in the lungs or bleeding in the kidney in the form of glomerular bleeding. Vasculitis harms organs by causing them to bleed uncontrollably. And that's what palpable purpura vasculitis is. And I'm slowing down to sort of try to digest this concept with you as we go through this case together, but then getting the pathophysiology right here is key. What is happening here is ischemic necrosis of blood vessels. This is what's called retiform purpura. And what is the pathophysiology of retiform purpura? We see it in much more simple situations. It's the same pathophysiology of ischemic colitis, or the same pathophysiology of a hemorrhagic conversion of an ischemic stroke, where you have blood vessels that are hypoperfused, that are fragile and bleed. How do you know that here? You know that here, I think the best example I can give you is you're seeing, maybe I can step up here, is you're seeing these little circles. Those circles should evoke the idea of livido And livedo exists on a spectrum of livedo reticularis, racemosa, and then retiform purpura. And the idea there is just how much of a complete ring you have of these hexagonal planes. What are these things representing? They're representing compensatory dilation of the superficial vessels. Why? Because the deeper dermal vessels are thrombosed and completely occluded. So the superficial capillaries try to compensate for that by allowing the blood to circulate on the surface. And if that happens too much, they burst and bleed and you get the purpura. And the more and more and more the ring is formed, the more and more compensation is happening at the surface, and this more and more serious the underlying thrombotic issue is. And I don't need to convince you how serious this is, it's everywhere. So what's happening to this person? His dermal blood vessels are ischemic everywhere. Now that's a very rare problem, and it predicts with a high degree of fidelity that the patient is having multifocal small vessel thromboses in many different places, potentially explaining everything in his viscera. It also, just for the sake of time, predicts a high degree of a paradoxical lab situation where the labs will likely look that this person is meant to bleed, that they have a high INR, high PTT, and low platelet count. So if you just looked in the labs in isolation and didn't see the patient, you would think this person's going to bleed. But in fact, they have the exact opposite problem. They're clotting off like no other. So if I saw this in real life, I would be very, very worried about the patient. And I would wonder if the labs will reinforce this hypothesis by being paradoxically suggestive of bleeding, when in fact, they are really painting a picture of severe aggressive thrombosis.
Thank you for that. Do you think his TIA 5 months earlier is related to this, unrelated? Kind of how do you put that in your...
Yeah, I think that it really has, sort of like, I think this illustrates to you how different people think. I don't know if you would get a uniform answer to that question. I'll just share my vantage point. When somebody is so sick, I don't want to limit my diagnostic hypotheses by analyzing any coexisting data. I'm not analyzing whether his alcohol use disorder or the dog bite or TIA is relevant, because what those naturally do is they shorten the list of things that you may consider. All I'm trying to think about right now is what I know I need to explain, and I need to explain all this hectic devastation he has, and would be mindful of any additional data point that funnels the differential diagnosis too soon. Now, 3 aliquots from now, his TIA may be incredibly relevant, or the dog bite may be incredibly relevant. But right now, if you're using it to generate more hypotheses, more to you, that's exactly what we need to do. I think we have to think more and more and more about what's going on and not use things to funnel our diagnostic hypotheses simply because she's just too sick for that.
Got it. And so if you are sort of categorizing things as more or less likely, maybe taking it into account, but that won't change kind of your workup moving forward, because you're going to look for even the less likely things. Is that
exactly?
Okay, great. So this is how this mottled rash was described by our dermatology colleagues, as you've alluded to. So cool, insensate, dusky hands and feet with weakness, non-blanchable, some areas of necrosis on some fingertips, mottled, non-blanching purpura on the shoulders, abdomen, thighs, coalescing with increasing confluence, and 3 healing deep puncture wounds in the right dorsal forearm without signs of superinfection. Okay, we went through here, but anything to amend based on that description there?
Not based on the description. I just feel so lucky to be sharing the stage. But that was just one of the best responses, man. That was amazing. I'm in awe.
Me too.
Yeah.
So we can move on to the next step, which is data, casting a broad net, as you've alluded to. So the fishbone CBC here is not an error. The white count really is 26, and the platelets are 8. It's not reversed. Hemoglobin was low at 8.3. His sodium was slightly low at 133. He had a profound AKI to 5.5 with a baseline of around 0.8. His hepatocellular enzymes were elevated with an AST of 443 and an ALT of 1305, and his T-Billy was 4.8. You had mentioned the threshold of 3, so may explain the sclerolicterus, but I'll let you
I'm glad I contributed something to that.
His NT-proBNP was 64,000. His troponin was sort of peaked at 540. His CK was initially 14,000 and went up to 69,000. INR was elevated to 1.6 and his CRP was high at 48. Alcohol level was undetectable. Thoughts on this?
Yeah, where are my residents in the room? Residents, don't be afraid. I'm not going to call on you. Yeah, I see all you. When you see these labs finding, doesn't it scare you and overwhelm you? And that's natural. It should scare you and it should overwhelm you. The best advice we can give you is focus on the lab abnormalities that are so significant and ultimately may help you in diagnosis or management. To give you an example here, we have a CK that's 69,000. So what are we worried about? We're worried about renal injury. We have a high creatinine. Oftentimes the kidneys are a bystander in a devastating multisystemic illness. Rarely are they a clue to the diagnosis. It could be that we might be dealing with something more exotic than just pre-renal azotemia or ATN in the context of sepsis. But we have a low-hanging fruit that we need to treat and give this patient a lot of fluids and trend that CK. Then you look at the CBC, and I would argue that the most impressive abnormality here is the thrombocytopenia. This for sure, you have a bicytopenia, and when you're approaching cytopenias, the rule of thumb is if one is down, hang out in the periphery, but if two or more are down, go towards the bone marrow as a general guidance. With this thrombocytopenia, with this anemia, with this elevated INR, with the beautiful discussion that Rabih had of in situ thromboses, you're wondering, is this patient in rip-roaring DIC? That's my reflexive thought. Of course, you can be more analytical and system 2 about it, but I would have to first convince myself I'm not dealing with the ramifications of this multi-systemic disease that's primarily leaving its footprint in the microvessels that are supplying various tissues. And it makes me reconsider the polyneuropathy. Without the skin findings, I would have prioritized demyelinating polyneuropathy, but now I'm worried about the vessels that are feeding the nerves, the vasa nervorum, and can you have in situ thromboses of these vessels that are leading to the paresthesias that this patient is experiencing. With the heart, again, in the setting of this rip-roaring sepsis, I would just label this sepsis for now. You wonder, is this just a stress-induced cardiomyopathy, or is the underlying process also invading the myocardium? Meaning, can this be a myocarditis? We would continue to trend out the troponins. I'm happy to see that it's already downtrending. The other very significant abnormality is that AST and ALT. You have to be cautious with interpreting AST and ALT when you have another reason for its elevation being muscle lysis or rhabdomyolysis, which we'll put into the AI. But remember that ALT is more specific to the liver, while AST is more present everywhere. And AST actually has a shorter half-life than ALT. ALT has a longer half-life. So you can sometimes have processes that are actually respecting the AST being higher than the ALT, but the AST shrinks quicker because of its shorter half-life. But in this case, this is making me wonder, is the liver also shocked? Or is the underlying process also involving the liver? You know, I think it's really important, like when we see someone with chest pain, we think about ACSPE dissection. When you see someone with these abnormal liver chemistry tests, you have to ask the question, is the patient in acute liver failure? And the answer to that is, do they have the encephalopathy and do they have the coagulopathy? So I'm going to be watching that liver like a hawk. So what has all this done for me? Management-wise, I'm giving this patient antibiotics. And if you ask what antibiotics, in addition to the broad spectrum, maybe vancomycin, I'm also going to focus on the dog bite and say, hey, Google, AI, whatever you are, what other like anaerobic organisms do I need to cover from the dog bite to make sure I don't miss that? Giving this patient a lot of fluids, and I'm trending that CK, I'm trending the creatinine, and I'm going to see what happens to these liver chemistry tests. And we once had a case on our podcast where someone had a shock liver that then led to gangrene in the distal extremities because of the half-lives of the clotting and anti-clotting factors and the imbalance that happens. When I wave my hands like this, I don't remember the exact mechanism, but there is an imbalance that ensues.
Fantastic. Yeah, thank you. Yeah, anything to add? Yeah.
One really quick question. So, I'll keep this brief because I know we have more to get through. As Prof. Rez was talking, I was realizing the number of things that you have to manage in real life is overwhelming. And I'll just say, I think I would be really worried in this situation about the camouflage effect. What I mean by that is, yesterday, 2 days ago, my dog had a massive swelling of his right eye, abruptly and for no clear reason. And my very astute wife, who's in the audience, went and searched through his hair right next to his eye, noticed a tiny little tick. And that tiny little tick caused absolute chaos around his eye. And I think that's what we have to do here. This person's whole body is being destroyed by a response to something. And the question that we have to figure out is, where is that tiny little tick? And I really, really worry that a case like this can be so overwhelming because the body's response is so severe and so hectic that it makes it very difficult to figure out where is that tick attached. Now, is it that bite at the tiny little bite with no signs of infection on his arm? But I think in all likelihood, you need to look super thoroughly on exam and through visceral imaging about noticing that one piece of asymmetry. Is it a focus in the lungs? Is it a focus in the liver that allows you to say, that's the issue? And then everything else is the body's hyper exuberant response that's shutting everything down.
Fantastic, thank you. So not getting sort of waylaid by one of these abnormalities, but trying to look at them in some and figure out what the instigator may be. Dr. Bonfield had a question in the audience.
Yeah, feel free to skip it if it's going to take too long to answer, but I'm just curious, everything you think is going on and the risks and benefits, would you prioritize transfusing a unit of platelets?
Yeah, I wish we wore our DX shirts to emphasize our strong opinions in the realm of diagnosis. To see the treatment and supporting this patient is so complicated. I think the things that would be crossing my mind in terms of the bleeding risk for this patient is this person in the early phases of DIC, where I've seen experts like yourself recommend a heparin drip to prevent them from clotting? And so my honest answer is that is at a zone of tremendous uncertainty for me, and often is a zone of tremendous uncertainty for experts in your space. So I think the conversations would be, do we support this patient by giving them things that will help them clot? Or counterintuitively, because we think they might be in that early phase of DIC, do we give them a low-dose heparin drip to prevent them from doing so? And I'm so glad that in real life, I would be using your brain power to help me make that decision.
What would you do, Sam?
This is so hard.
Yeah.
Honestly, I don't know.
Yeah.
I'd probably recheck it and see what the
Yeah.
And if it's getting up closer
Right.
to 10 and staying there, I would probably hold on.
My sense is that supporting this patient is sort of the marvel of the 21st century. To be able to have this person have even a fleeting chance of surviving is because of the supportive care that we can offer in that realm. But also, I think that can't distract from the attempts to figure out what the source of all this is. Because I think something very small that is imperceptible is causing this chaos. And where is that thing? And getting to the root of what that is key. So if he has a tiny little abscess underneath that wrist bite, you get that drained, you might be able to have a much more profound return on your investment. Or if you find a focus of asymmetry viscerally that you can address, I think that'll be huge.
Fantastic, thank you for that question too. I'm going to sort of speed through the next couple of slides with regards to imaging and let you know that the ankle brachial index showed there was absent flow in the distal right and left great toes. And then he had a CT angiogram of his legs, which showed The right leg had complete occlusion of the anterior tibial, perineal, and posterior tibial arteries, some macrovascular arterial occlusion there. And I think I'm just going to take the liberty of moving on to the next tests so that we can talk about how this additional testing, you had mentioned, DIC, what is that? How does this factor into how likely you think that is at this point?
I'll just share some real quick reflections. I think what we are seeing is a sort of a near incontrovertible evidence that the patient has microangiopathic hemolytic anemia because we see evidence of its cousin, thrombotic microangiopathy, and that is evident on the skin. And then we see schistocytes, a very high LDH, unconjugated hyperbilirubemia, and haptoglobin. The most common cause of microangiopathic hemolytic anemia in the context of an acute hectic illness is DIC. DIC assumes that there is no underlying internal propensity of the body to do so, and the onus is exclusively on the driving process, acutely an infection, chronically a cancer. However, there are other forms of microangiopathic hemolytic anemia / TMA that are more complicated, that have to do with a patient having internal vulnerability, waiting for a trigger to pounce. Antiphospholipid antibody syndrome is an example of that, which this person certainly is a candidate for. Atypical hemolytic uremic syndrome is a candidate for that, which this person could have. I think what you're trying to figure out fundamentally is this new disease that has been laid upon this patient causing this entire picture, or did it capitalize on a pre-existing vulnerability that they have to trigger atypical HUS or antiphospholipid antibody syndrome? If you use the skin thromboses as a filter to say which TMA / MAHA has a propensity to do what it does to the skin, DIC with better form purpura and APS. Other forms of thrombotic microangiopathy like TTP, like HUS, typical, tend to involve the viscera and spare the skin.
Fantastic. So I'll just provide a little more info about the clinical course as we reach the end of this case. So as you alluded to, he was critically ill. He was admitted to the ICU. There was concern for disseminated intravascular coagulation versus thrombotic thrombocytopenic purpura. Started on dialysis because he was anuric, unfortunately, with the AKI. He got a skin biopsy and he got plasma exchange out of concern for TTP. And I'm just going to breeze through this in terms of the additional testing that we got. You can see here a significant infectious panel was sent with a lot of viral testing, which was all negative. Quantiferin gold, tuberculosis was negative. ADAM TS13 was high at 34%. Respiratory testing didn't show an infectious cause. And then the results of his skin biopsy showed fibrin thrombi, including the lumens of some small superficial vessels, only sparse infiltrate of neutrophils and nuclear dust. Some parts of the epidermis had necrosis, as you alluded to, immunofluorescence with no significant IgM, IgA, or complement, and no evidence of leukocytoclastic vasculitis. Infectious studies on the biopsies were negative. So, final thoughts on a unifying diagnosis. Easy to get in the weeds of sort of the hematology of this, but given everything you've learned in terms of the history, if you had to put your dollar down on what set this all into motion, what would you say?
Allison, do we have a minute to do a pair share where they can put their money down, or is there not enough time?
I wish we had a little more time. Yeah.
Are you down with what we had talked about? Okay. I think we're going to end with capnocytophagia. Okay.
Fantastic.
Because Harry said so 10 years ago.
That's fair. And so I guess, how do you fit this case into your capnocytophaga illness script?
Well, I'm not even pronouncing it correctly. Capnocytophaga?
That's what I think. I don't know.
Yeah, no, I trust you. I think that we really, the acute onset, the devastating sequela, the history of the dog bite, and we ruled out TTP with that ADAMS TS13 that was elevated. So ultimately, if you were to ask me, like, what would I put into the GPT now? I would say 56-year-old, recent dog bite who's presenting with widespreading microvascular thrombi that's involving the skin, the liver, the muscles, the nerves. And I think when you put all that into it and you're not worried about antiphospholipid syndrome, because I don't think we have a great concern for that. It doesn't sound like it's catastrophic antiphospholipid syndrome, and it's TIA, it's hypertension, hyperlipidemia, all the right risk factors. I would wonder if it matches the illness script for capnocytophagia from the dog bite.
Absolutely. Well, great. You are correct. The next-gen sequencing did show capnocytophaga caenomorsis from that dog bite, sorry to say. And so the final diagnosis here was puerperal fulminant sepsis and thrombotic microangiopathy secondary to capnocytophaga infection following a dog bite. Fantastic. Thank you for leading us through that. I will transition now to a little further information about that disease process. We'll have Dr. Jack McGregor come up and give us some background. Jack is one of our infectious disease fellows here. He was also an IM resident and did his chief residency at the General. So we'll let Jack come up here and tell us a bit more about this diagnosis.
Podium, or do you want me with
Podium's fine, yeah. And you can just advance the slides right there.
By the second aliquot, that's amazing. Wow. So I'm Jack. I'm one of the ID fellows. I was at the gym when I got called about this patient, and they were like, could it be related to the dog? And I was like, probably. It could be capno. But here's a little bit about what you need to know. So on a microbiologic side of things, this is like a spindle-shaped gram-negative rod. It kind of looks like a fusobacterium. And the annoying thing about it is that it's going to be really hard to actually see in culture. Our microlab cannot grow the capno under the conditions it requires. So it requires like very low O2 and very high CO2, but it's not going to really like to grow in an anaerobic chamber. And so where do we find these? Areas with high CO2 and low O2 is going to be mouths, particularly of animals. And so I found a nice paper from like the veterinary literature where they swabbed like thousands and thousands and thousands of animals' mouths. And unfortunately, Rabih, for dogs, about 41% of them are colonized with capno, but also cats as well, about a fifth. And then sheep and cattle for your patients who are ranchers also can carry capno. If you are concerned about this and are looking for a pet for your child, hamsters and pigs had zero capno. So a micro pig may be the next hot trend for 2027. And so how do people get this? Because it's a mouthful, it's usually going to be a bite, but other ways people can get it, cats, they lick their paws, they scratch you, and then you get capno that way. And then another thing I like to ask my patients is like, does your dog ever lick your wound on your foot? It is more common than you think. And that is another way that people get these kinds of infections. And then last thing to note is that it is encapsulated, so that does put certain patient populations at risk for developing capno. So who gets it? Main study was out of the 1990s in Denmark, where they looked at every single patient who had capno in their country, and 76% of those patients were male. A fair amount of those patients had asplenia, so this is where the encapsulated piece comes in. But I think the big takeaway is alcohol use disorder is a very, very high risk for developing severe infection with capno, particularly severe infections like our patient had leading to DIC. As a bacterial infection, immunosuppression does put you at higher risk for this, but of the 70 patients they looked at in Denmark, 40% of those were immunocompetent. So it's just not the immunosuppressed who get it. And then what does the disease look like? So as Rabih and Reza pointed out, this is an acute process. Usually the incubation is going to be somewhere between 1 to 8 days. Most patients start off with like a flu-like illness. It's like sore throat, malaise, usually some sort of fever. And then the 3 big complications we worry about is meningitis, which was in a fair amount of those patients in Denmark, endocarditis, and then the one we really care about is what our patient presented with, which is sepsis and bacteremia. This patient, or sepsis with capno, carries about like a 30% mortality, so quite severe. And so how we actually diagnose it, like I said, you're not going to culture this in time for it to actually matter. It's going to take 14 days of growth on specialized media. And pretty much what I do as the infectious diseases fellow is I call the micro lab and are like, can you please hold the plate for longer and see if you can plate it on anything that might grow out the capno? They'll say, we'll try. But really, MNGS probably has a better role here. And so I think 2 weeks ago, Dr. Spottiswoode and Dr. Simmons from the ID division gave a talk about the role of MNGS, when it's useful, when it's not. This may be one of the situations in which it's actually useful. And then treatment-wise, what should you be picking up front if you're concerned about capno? The great news, it's not really resistant to most things. So the standard sepsis treatment of vancomycin or vancomycin will be fine and will cover the capno. The preferred treatment is penicillin, or usually a beta-lactam, beta-lactamase inhibitor like piptazo or ampicillin sulbactam. And then the one thing to note is that if you are discharging this patient before they're done with antibiotics, Bactrim is not the choice as it is intrinsically resistant. Which this patient was not going to be discharging from the hospital given how sick he was. But if you're in the ED and discharging someone after a dog bite, Bactrim would not be the choice for antibiotic. And so that raises the question for why do some bacteria cause these horrible DIC pictures and some don't? What I will say is that for capno, nobody really knows. So we have to go back to how do other bacteria that we have more experience with cause these kinds of things. But just for capno alone, about 35% of patients who get sick with capno develop this picture. Maybe to not this degree of severity, but they do fall on some sort of DIC spectrum. And then in case reports and case series, TMA and purpura fulminans are a not uncommon sequelae. And one thing that I found interesting was in that Denmark paper of the 10 patients who died of this, half of them had Waterhouse-Friderichsen syndrome, which is, if you remember back to studying for SEP1, this is that bilateral infarct of your adrenal glands that you get from usually Neisseria meningitidis. This causes the same thing. And so quite a potent pathogen. And so how does this cause it? When I think of patients with a bacterial infection and some sort of MAHA, first thing that comes to mind is E. coli 0157H7, which is that Shiga toxin producing one. Capno isn't actually producing a toxin that's destroying your red blood cells like the E. coli or Shigella does. And then the other one I think about is Neisseria meningitidis, which classically causes purpura fulminans. So I don't know if there's any students in the room, but if you're studying for your test and you see the word purpura fulminans, the answer is probably going to be Neisseria meningitidis. In real life, not the thing, but in step one world, it is the thing. And the way Neisseria does it is it use it as adhesant to bind to the vessel walls. And in what I can only describe as an Attack on Titan style lysing of your blood cells, it uses its pili to basically aggregate platelets and cause a DIC that way. And so unfortunately, we don't really know why capno does this, but some of the papers I was looking at was maybe it's the capsule related, maybe it's a certain polysaccharide related, but right now capno is not important enough that people are really looking into this. And so since this is CPS, I wanted to leave you with my illness script for capno. So if you see a patient with alcohol use disorder who's coming in with a dog bite and they're really sick, almost out of proportion to their vital signs, they've got some sort of coagulopathy, but nothing's growing out on the culture, I want you to think about capnocytophaga, and your treatment's going to be usually ampicillin sulbactam or piptazo. But if usually when they're this sick, this is going to be part of your empiric regimen. And that's all I got.
Thank you. That was fantastic. And thanks to our problem solvers here. I wondered if you have other comments about the case, Dr. Hollander, too, if you have any comments as well, not to put you on the spot, but just open, or questions from the audience.
I think, first of all, that was brilliant, Jack. Thank you for that. I wish I had that knowledge before this case. My only comment is I just want to express gratitude. Gratitude to Rabih for letting me be here. I mean, I bleed UCSF. while I'm at UCLA. Gratitude to Allison and Bob for having me here. And most importantly, gratitude to Harry Hollander, who's the reason, one of the main reasons that clinical problem solvers exist. Not to, put attention on him, but just immense gratitude to all of you.
And thanks to you two for being here, of course. I think we all learned a lot.
Yeah, I know Dr. Wachter is watching this. Please invite me again for next year.
I'll make a note of it, yeah.
Make two brief comments to Jack's.
We'll just give you the handheld mic if you can speak into it. Thank you.
To add to Jack's methods of transmission of this bug, years ago at Parnassus, we had a patient who the diligent ID fellow discovered that person with this exact syndrome shared his toothbrush with his dog. So that is probably not recommended. And I learned about this in a patient in my longitudinal HIV practice who had previously been splenectomized for his refractory TTP. This person luckily had about 7 lives. And then when I was away on the East Coast over the Christmas break, I got called from the ICU that here he was in the ICU with sepsis and just devastatingly ill, and a skin rash that looked like this. Well, it turned out that he was a dog walker by profession, and I had had several conversations with him that he needed to get a new profession. And he had, like this person, a trivial bite from a little small weenie dog that wound him up almost, mortally ill in the ICU.
Wow, thanks for sharing. Yeah. Can give a little bit of follow-up of this case. He had a bit of a tough course in the ICU with dry gangrene, unfortunately, of his fingers and toes. He had candidemia, he had pulmonary aspergillosis, but he did make it out of the hospital. So, and I just also wanted to acknowledge our fantastic chief residents, Drs. Morogi and Tran as well, for helping to prep this case.